Yeah, hello guys. Good evening, all of you. I hope audio video fine. Please confirm once. Okay, so that we can start. Okay, great. Yeah, good evening, बच्चे लोग. So today we are going to discuss some important topics. Predictor series for INICET Pharmacology. The topics are general pharmacology, autocoids, antibiotics, anti-cancers, immunomodulators. You know, in INICET these topics are very important. So we are going to discuss some important MCQs. Please don't forget to revise these topics. I am your faculty, Dr. Dinesh, and this is about me. Now, without wasting the time, let's discuss some important topics. They will be asked, so you can take the screenshot of this slide, and these topics are important for INICET exam. Okay, so let's start with the question number 1. Which novel oral, the question is about which novel oral antifungal targets the glucan synthase complex and is effective against age-old resistant candidiasis, and especially it is used for vulvovaginal candidiasis. Vulvovaginal candidiasis. Can you tell me the name? The options are isavuconazole, fosmanogepix, ibraxafengerb and rezafungin. These are the drugs. You can see by the name these are against fungus. These are active. Isavuconazole is one of the azole. I hope you know. So these are all important drug for fungus. Now let's see. So what is the correct answer as per your opinion? What is the correct answer? Okay, so let's see about the options first. Sir, isavuconazole is azoles. Sorry. Isavuconazole is the, what is happening? Isavuconazole is the azole. They are asking the azoles resistant. Second is this fosmanogepix is the drug which is inhibiting this enzyme GWT1, and this enzyme is crucial for synthesis of GPI, which is important for fungal cell wall. The ibraxafengerb, that is the first in this class triterpenoid antifungal drug, which is definitely similar to echinocandins, but the important thing is it is the oral drug and it targets the same beta-1,3 glucan. These fungins are echinocandins. They also target the same, but they are not used orally. Right? So yes, now the answer will be C, ibraxafengerb. So it is the triterpenoid antifungal. It is targeting the beta-1,3 glucan. It is mechanism is similar to echinocandin like caspofungin, anidulafungin, etc. But these are the new antifungal drug. Don't forget to revise the mechanism of antifungal drug. They are frequently asking the mechanism of antifungal drug and drug of choices. So the correct answer in this case, right? So this is the correct answer. Option C is the correct answer. So don't forget to revise antifungal drug. What is that? Don't forget to revise the antifungal drug. Okay, let's see the next question. Which newly approved drug is an oral calcitonin gene related peptide antagonist for migraine prevention, or you can say the prophylaxis? So can you tell me, bache, which is this drug? Newly approved, and it is the oral CGRP antagonist for prophylaxis of migraine. Options are ubrogepant, erenumab, rimegepant or atogepant. Which is this, bache? Yes, tell me. So this is CGRP antagonist. So you know the CGRP antagonists are CGRP, means these are the gepants, suffix is gepant. Erenumab, that is one of the monoclonal antibody, and that is also targeting the CGRP, but that is not the antagonist. These are the antagonists. So we have these options. Now out of these we have to select the oral drug. And it is only and only used for prophylaxis. Yes, so it is the atogepant which is the oral newly approved drug CGRP antagonist approved for migraine prophylaxis. If you talk about the ubrogepant, that is approved for treatment, acute attack as well, not for prophylaxis. Monoclonal antibodies are definitely not orally drug, they are the injectable drug. So the correct answer is atogepant. It is CGRP antagonist. For migraine prophylaxis, it is approved for migraine prophylaxis, not like the ubrogepant, which is approved for acute as well. So that is correct about the atogepant. Understood? So again, one frequently asked topic is the drugs for migraine. Let's see the next question. A patient with ulcerative colitis is prescribed ozanimod. What is the mechanism of action of this drug? So options are integrin alpha 4 beta 7 blocker, JAK inhibitor, Janus kinase, S1P receptor modulator, or TNF alpha antagonist. Again, the important drug for inflammatory bowel disease. So many new drugs are coming and these are important. So what is the correct answer? So you can rule out the other options. If you see the integrin alpha 4 beta 7, can you tell me the name of this drug? Any bacha? Can you tell me the name of this drug? So this is vedolizumab. You know the other drug natalizumab, that is alpha 4 beta 1, that is for multiple sclerosis. This is vedolizumab. Janus kinase inhibitor, these are cetinib, tofacitinib. Tofacitinib, ubrocitinib. These are type of drugs are there. Upadacitinib. Then we have the TNF alpha antagonist, and I hope every bacha knows about the TNF alpha blockers. We have the A, adalimumab, then we have the C, certolizumab. So one alphabet is missing, B is not there, then D is not there, then we have the E, etanercept, then we don't have the F, then we have the G, golimumab, we don't have the H, then we have the I, infliximab. So these are the drugs which are TNF alpha antagonist. So guys, now we have the S1P receptor modulator, that is the correct answer. If you see the detail, it is the drug which is targeting the S1P1 receptor and also targeting the S1P5 receptor. So it is targeting the 1 and 5 receptor. By this, it can definitely decrease the migration of lymphocytes and control the inflammation. So it is the S1P receptor modulator, sphingosine 1-phosphate receptor. That is important for anti-inflammatory purpose. Okay. So yes guys, this is about the option C. Now let's see the next question. Which one of the following novel drug is used for ALS and modulates the RNA splicing? What is the drug? Approved for amyotrophic lateral sclerosis. Options are riluzole, options are edaravone, option is tofersen and trofinetide. This is the old PYQ which have been asked. Trofinetide, that is for Rett syndrome in children. Rett syndrome, one of the childhood disorder. So obviously trofinetide is not the option. Rest of the three drugs are approved for ALS. These drugs are approved: riluzole, edaravone and tofersen. So what is the correct answer out of these? Yes, very important topic again. So what is riluzole? Riluzole is one of the drug, NMDA blocker. Edaravone, that is one of the free radical squenger. See the name, radical squenger. So it is the free radical squenger. And we have the tofersen. So by name only you can see it is the drug. Tofersen is the drug. It is the answer. This drug is antisense oligonucleotide. Antisense, tofersen. Antisense oligonucleotide, that is targeting the superoxide dismutase 1, SOD1 mutation for ALS. In ALS, some patients are having this mutation Because mutation in superoxide dismutase gene, it is causing a subset of this ALS, that is one of the familial ALS. So some of the patients are having this gene mutation. So this is basically SOD1 is an antioxidant enzyme and that protect the cells from damage by the superoxide radicals. Because of the mutation ALS occur, we can give this tofersen drug which can inhibit this SOD1 mutation. It is the antisense oligonucleotide. Clear? So guys, this is the correct answer. Option C is the correct answer. So again, a very important topic, tofersen for ALS. Now let's see the next. Which agent is a new treatment for SMA? SMA is again a hit topic nowadays, and I hope you know why it is the hit topic, because the enzymes used for this purpose, they are basically orphan drugs. And you know, the orphan drugs are the drugs used for rare disease. They are very costly, very difficult to get these medicines. And you know, nowadays tariff war is there, so because already they are costly, and because of this tariff war they will be more costlier. So crores, you know, 16 crore, 15 crores like that. So guys, that act via SMN2 gene. You know, there are two genes, SMN1 and SMN2. So this acts via SMN2 gene splicing modulation. Modulation means it can change this. So options are nusinersen. See the name arsen, that is the oligosense nucleotide. Then onasemnogene, risdiplam, or viltorlarsen. So these two are having the similar suffix. This is different and this is different. So what is the answer, bache? What is the answer? Let's see what is the correct answer. So for SMA, a new treatment which acts via modulation of SMN2 gene splicing. Okay, let's see the options. So the first is nusinersen. The first is nusinersen. In the nusinersen, it is the antisense oligonucleotide, and that is definitely used for SMA, but the mechanism is not same. The second is onasemnogene. That is again important. That is a treatment used a modified virus to deliver the functional SMN1 gene, but we are asking about the drug which is targeting the SMN2. Then we have one drug, risdiplam, that is basically targeting the SMN2 gene. I will tell you how. And one drug I told you about, the viltorlarsen, that is a drug which is targeting this PMO, a phosphoradamidate morpholino oligonucleotide. But simply you can remember the PMO, and it is not for SMA, it is for DMD, Duchenne's muscle dystrophy. So this viltorlarsen for Duchenne's muscle dystrophy, not for this purpose. Rest of the drug can be used for SMA. This risdiplam, this drug is important, a new drug approved recently. It is basically orally used small molecule. It is improving the SMN2 splicing, and because of that there will be increased SMN protein in the SMA patients. So you can see it achieved this by modifying the splicing of SMN2 gene, especially promoting the inclusion of exon 7. So basically what happens, this inclusion of SMN2 gene, that is providing the full length SMN protein, and that is helping to compensate for the deficiency of mutation in the SMN1 gene. So you can see it is one of the another option. It is one of the another option. You are providing the SMN2 modulation, and because of that there will be compensate for deficiency of the SMN1, and this is risdiplam. So it is the new drug approved for these patients. So what is the correct answer? If you see the option SMN2, so by options you can see it is the option C, risdiplam. Okay, so please again, SMA is important. Don't forget to revise the SMA. Okay, next, a very hit topic as usual. Which of the following is true about anti-tubercular drug? You know about ATT, every time they will ask the question about the ATT. So what is true about anti-tubercular drugs, about the ATT, especially the resistant patients? Options: isoniazid is a mycolic acid synthesis inhibitor. Is this true? Yes, this is true. Rifampicin is only used in TB. No, that is not used only for TB, can be used for many other purpose. It is used even in, Staph aureus. It can be used for meningococcal infection. It can be used for H influenza. And even in the mycobacterial, it is used for leprosy. It is used for atypical mycobacteria. Then pyrazinamide induced CYP. No. It is rifampicin which induced the CYP, not the pyrazinamide. And because of this, rifampicin is having lot of interaction. Then bedaquiline is the ATP synthase inhibitor. Yes, that is true. Delaminid, pretominid and bedaquiline. These are the three important anti-tubercular drugs. We should know the mechanism as well. So out of these, you can see 1 and 4 is true. So the option C is correct. Option C is correct. But we need to know the important details about the bedaquiline. We need to know the important details about the bedaquiline. Everybody knows about the bedaquiline. It's a new class of drug, which is one of the diaryl quinoline, but it is indicated only for combination therapy in adult patients who are more than 18 years. Only approved for pulmonary TB, and that is also the resistant TB. It is having better absorption. It is having better absorption when the drug is taken with the food. Empty stomach, the absorption is less. It is taken with the meals. QT prolongation is one of the risks. I hope every bacha knows. That is very important. QT prolongation can occur with the bedaquiline. Whenever you add the bedaquiline to the regimen, it is only and only given for the first 24 weeks of the treatment. Only for 6 months it is given. And there are many contraindications. But what are the absolute contraindication? What are the absolute contraindication? If first is because you have to explain the risk as well as benefit to the patient, to always take the consent. If the patient refuses to give the consent, then definitely absolute contraindication. In the high risk for cardiac complications, a patient is having history of MI, a patient is having history of arrhythmia, a very old patient, right? In these patients, because of cardiac complications, you cannot use. And some patients are having the history of allergy, then obviously we cannot use. Other than this, you cannot use in pregnancy, you cannot use in lactation, you cannot give for less than 18-year child. All these are contraindication, but these three are absolute contraindication because we don't have the data for pregnancy and lactation, so that is relative contraindication. Right, so these are the important points about the bedaquiline, and I hope every bacha knows the B-PAL-M regimen. That is very important. In B-PAL-M regimen, we have the bedaquiline, then we have the this pretomanid, then we have this linezolid, and we have the moxifloxacin. So B-PAL-M regimen, very important regimen, that is for 6-month oral regimen. 6-month oral regimen. So it is the completely oral short regimen for MDR TB, and we have the B-PAL, that is for extremely or pre-XDR or XDR TB used by the approved by the FDA. But in India, by Health Ministry, B-PAL-M has been approved especially for the MDR TB patients. Right. So this is important for MDR TB. Okay. So don't forget to revise the anti-tubercular, especially the newer anti-tubercular drugs. So the correct answer we have already discussed. Let's see the next question. A very important drug. I hope every bacha knows because Instagram reels also, showing this drug. All are true about new drug suzetrigine except. Tell me, bache. Having mixed action opioid and non-opioid. Inhibit the voltage-gated sodium channel in the peripheral pain-sensing neurons. Given empty stomach or risk of muscle spasm. All are true except about this new drug suzetrigine. Very important drug for pain relief. It has been approved. So tell me, bache, what is not true? So the option B, voltage gated sodium channels inhibit, that is true. Given empty stomach, that is also true. Risk of muscle spasm, yes, that is one of the side effects, so that is also true. It is having mixed action, no, that is false. It is non-opioid, that is the benefit. It is the non-opioid mechanism, that is the benefit. That's why there is no opioid like addiction. No opioid like addiction. No opioid like addiction, that is the USP of this drug. So option A is not correct. Option A is not correct. So you can see about the suzetrigine, very important drug. In this drug, you can see it is the non-opioid pain medication. approved by the FDA to treat moderate to severe pain in the adult patient for acute pain. It works by inhibiting the pain signals in the peripheral nervous system, especially blocking the voltage-gated sodium channels. Right, without any addiction potential of opioid, that is the benefit. And the common adverse effect of this drug include the rash, itching, skin problem, or muscle spasm. And because of that, it can increase the CK level, creatine kinase level as well. But we have also seen headache, so don't use this drug in the headache patient. We have seen the headache in some patients as well. These are milder, but some patients have reported the headache as well. So these are the important points, and as I told you, this drug is having better absorption, empty stomach, it is given empty stomach. Okay, so this is important. Now some mix match the drug with the adverse effect. Match the drug with the adverse effect or interaction. The drug in column A and the adverse reactions in the column B. Methotrexate. So you know methotrexate, important drug. Methotrexate is the drug which is folate antagonist. Azathioprine or allopurinol. Azathioprine or allopurinol. So if you see, this is causing myelosuppression. Then you can see fluoroquinolones. Fluoroquinolones can rupture the tendon, and omeprazole, that can cause the macrocytic anemia. You know the long-term use can cause this anemia. So these are important. So you can see the A4, then B is 2, A4, B2, C1 and D3. So that is the correct answer. So don't forget to revise some of the important adverse effect or interactions of the drug, especially the antibiotics, anti-cancer drug, or the long-term use of the PPIs, etc. So that is the correct answer. The next is again about the antibiotics, and in antibiotics some specific toxicity. They are frequently asking about the antibiotics and their unique toxicity. So we have the column A for drug and we have the column B for unique adverse effect. So can you match? Vancomycin, I think every bacha knows vancomycin causing red man syndrome, and the red man syndrome is because of the histamine release. The red man syndrome is because of the release of histamine. The only advice is give it slowly. There will be no red man syndrome if you give it slowly. If you give rapid injection, there is release of histamine. One more alternate drug we have. Can you tell me the name of this alternate drug which can be given instead of vancomycin, which is having the less risk of histamine release? The same group of drug. Any bacha, can you tell me the alternate? So we have one alternate drug and the name of the drug is teicoplanin. Teicoplanin is having the less risk. The same group of drug. Then the second is linezolid, very important drug. And this drug is having the risk of serotonin syndrome. It is one of the MAO inhibition, and because of the MAO inhibition, serotonin syndrome risk is there. The drugs which are MAO inhibitor, there will be more risk of serotonin syndrome, or if the drug is given with the another drugs which are increasing the serotonin level, there will be high risk of serotonin syndrome. Daptomycin, you know, one of the drug which is not available in India, but daptomycin is the drug which is acting on the muscle. It is important for the membrane, cell membrane. So it is basically causing the depolarization, and because of depolarization there will be the problem with the muscles. So muscular side effects will be there. Muscle depolarization, there will be muscle weakness, there will be muscle pain, and this is the daptomycin. It is the drug used for VRSA, it is the drug used for MRSA, resistant infection. But remember, daptomycin can be inactivated by the surfactant. This is the reason we don't use daptomycin in the pneumonia patients. We don't use daptomycin for the pneumonia because of this reason. In lungs, we have the surfactant and this drug can be inactivated. So, muscular side effects are there because it is causing the depolarization. Cefepime, can you tell me the generation of this cephalosporin? Any bacha? The generation of the cephalosporin, it is the pime. The pi is for 4th generation. It is the 4th generation cephalosporin. And it is having the risk of neurotoxicity. That's why 3rd generations are still safer. They are the primary drug. These are the reserve drug. Risk of neurotoxicity, especially in the kidney patient, you will see the seizures risk suddenly increase. So now you can see A1, Then we have the B2 and C4. So A1, B2 and C4 and D3. That is the correct answer. So don't forget these specific or unique toxicity. One more drug is there, that is chloramphenicol. And you know chloramphenicol causing grey baby syndrome. Right? So these are important. Okay. Chaliye. Let's see the next one. Again, one important question. Match the immunosuppressant. A very important topic, immunosuppressant and their mechanism or adverse effect. So match the immunosuppressant with their mechanism. So if you see cyclosporin and tacrolimus, right? Sir, how to remember? Bache, Aishwarya ji, no need to remember all the class, just remember the 4th and 5th. Just remember the 4th and 5th. In 4th we have the pi and in the 5th we have the role. Rest of the drug we are using mainly 3rd or 2nd generation. So just remember the 2nd generation, remaining all drugs are 3rd generation. So generations are not commonly asked, very rarely they are asking about the generation, but remember the new generation, 4th and 5th, pi and role. Then guys, we have the drugs, immunosuppressants and their mechanism. So this drug cyclosporin and tacrolimus, they are inhibiting the calcineurin. So they inhibit the calcineurin pathway. Sirolimus is the mTOR inhibitor. Sirolimus is the mTOR inhibitor. Azathioprine, by name only you can see it is prin. It is one of the purine analog. So it converts to 6-mercaptopurine and then it is inhibiting the purine synthesis. Azathioprine, it is one of the important purine analog. Methotrexate is folate. Azathioprine is the purine. Mycophenolate is very safe drug. Risk of nephrotoxicity is not there. And this is the drug which is inhibiting the IMP dehydrogenase enzyme. So these are the important mechanism. These 4 mechanisms are frequently asked. One is calcineurin inhibitors. In that we have the cyclosporin and tacrolimus. Then we have the mTOR inhibitor, that is sirolimus and everolimus. In this we have the tacro. Then we have the azathioprine and we have the mycophenolate mofetil. Out of these, mycophenolate mofetil is not having nephrotoxicity. Otherwise, most of these are nephrotoxic. So you can see A1, B2, then we have the C4. So this is the correct answer. Okay. Okay. Chaliye. So next, a very important again about the anti-cancer toxicity. A patient who is receiving doxorubicin for lymphoma is co-administered a drug to reduce cardiotoxicity. You know the ruby is due to red. So it is due to iron overload. This iron overload. Can you tell me, bache, iron overloading causing one cardiotoxicity? Can you tell me the name of this cardiotoxicity? Which cardiotoxicity is seen with the iron overloading? Medicine question. One important cardiotoxicity due to iron overloading. Yes, bache. Which is this? So this is DCMP. This is DCMP. I hope you know that. Dilated cardiomyopathy. Dilated cardiomyopathy. So which drug is this and how does it work? Leucovorin bypass the DHFRs, that is for methotrexate. That is for methotrexate toxicity. Leucovorin is basically the tetrahydrofolate. So that is for methotrexate toxicity. Then we have the dexrazoxone. So this razo is for red iron and it is iron chelator which is preventing the free radical formation, is used for this purpose. So to prevent this DCMP we use the dexrazoxone, iron chelator. Yes, very good guys, very good. Then we have the mesna mercaptoethane sulfonic acid, that is for cyclophosphamide. That is for cyclophosphamide, ifosfamide, for this purpose. Amifostine is the thiol squenger and that is preventing the nephrotoxicity and it is given with the cisplatin. It is given with the cisplatin. You know with cisplatin what we use? With cisplatin we use the normal saline because in normal saline we have the chloride ions, and these chloride ions are preventing this nephrotoxicity. With this we need to give the diuretic. Which diuretic is commonly used? With this we use the mannitol. If mannitol is not in the choice, then only we use the furosemide, but we prefer the mannitol. And then we use the amifostine. So these drugs are given to basically avoid this nephrotoxicity. So this is for platinum compounds. So answer B. So for rubicin, like doxorubicin, daunorubicin, doxorubicin is also called as adriamycin. So these are the basically anti-tumor antibiotics, and we are using dexlazoxone. Okay, so this is cardiomyopathy prevention. Okay, let's see the next question. Very important topic, resistant MRSA, VRSA. A patient on fluoxetine for depression start linezolid for MRSA pneumonia. You know we cannot use daptomycin, I told you, because in pneumonia, lungs surfactant, daptomycin will be inactivated. Within 24 hours, they developed agitation, sweating, myoclonus and hyperreflexia. The agitation is there, sweating is there, myoclonus, hyperreflexia is there. What is the underlying mechanism for this interaction? Yes, bache. What is this? The patient fluoxetine and linezolid. So excess dopamine activity, inhibition of GABA receptor, combined MAO inhibition and serotonin reuptake inhibition, and NMDA receptor overactivation. What has happened? This fluoxetine is SSRI, and I told you this linezolid is MAO inhibitor. If you give these two drugs in combination, you know what is going to happen. It is the very important thing, because linezolid is nowadays used for TB as well. That's why we should know about the adverse effect of linezolid. My request to all of you that please revise the predictor of last November 2024 as well. In pharmacology, I have discussed some important topics for prediction in November 2024, and this. With this, you can revise the PYQs, PYTs. These are very important, and obviously, don't forget to revise our DVT. So this is a very important combined MAO inhibition serotonin uptake, and also don't forget is fluoxetine and tamoxifen drug interaction. There are some important drug interactions which are supposed to know. So guys, tamoxifen and fluoxetine interaction. Any bacha, what happens due to tamoxifen and fluoxetine interaction? The effect of tamoxifen will be more, or the effect of tamoxifen will be less? Any bacha? Because tamoxifen is metabolized by CYP2D6. So what is going to happen with the fluoxetine and tamoxifen? The tamoxifen effect will be more, or the tamoxifen effect will be less? Tell me. Because it is metabolized CYP2D6. So fluoxetine is the inhibitor. Fluoxetine is the inhibitor of CYP2D6. So now you can tell me what is going to happen. But don't forget tamoxifen is the drug which is pro-drug. Tamoxifen is the pro-drug. It is going to be activated by CYP2D6. So if it is not going to be activated, what happens? Decrease the activation of tamoxifen. If the activation will be less, then what happens? If the activation will be less, there will be no effect of tamoxifen. So fluoxetine is going to cause tamoxifen failure. Fluoxetine is going to cause tamoxifen failure. Decrease activation. So there will be no effect. So don't forget tamoxifen is the prodrug. It is inactive form. And you know tamoxifen is having the ocular side effects as well. Okay. So clopidogrel omeprazole interaction. Same prodrug clopidogrel. Omeprazole suppress the activation. CYP2C19 and tamoxifen is CYP2D6. Okay. Chaliye, next question. A patient with non-small cell lung cancer, you know, without this the exam is not over. It is having an EGFR exon 19 deletion, started on osimertinib, a very important drug. Why is osimertinib preferred over the other first generation TKIs like erlotinib, geftinib? Why? Irreversible inhibitor of ALK, avoids T790M mediated resistance, inhibit the EGFR ligand binding, better P glycoprotein substance clearance. So why we prefer the osimertinib? I hope every bacha should know about the osimertinib. It is the third generation and everybody should know about the osimertinib, important drug for non-small cell lung cancer. So where we use the osimertinib? We use the osimertinib to avoid the resistance due to T790M mediated resistance. A very important, very important. So let me tell you the detail. Ki sir, erlotinib and jaftinib. These are the first line drug. These are the EGFR inhibitor. These are the first line drug. But whenever there will be mutation T threonine to M and the position is 790, so T790M mutation is there, then we use the osimertinib. So remember, T790 we use the osimertinib. Osimertinib is the new drug approved in 2023 only. And don't forget this threonine and methionine. And these are the generations. First generation, that is the reversible TKIs. These are erlotinib and jaftinib. The second generation is irreversible, and that is afatinib and dacometinib. So remember, dacu dekh ke fat gayi. So dacometinib and afatinib, erlotinib and jaftinib. Easy. So easy is reversible, then daco and fati is this irreversible. And then third generation, so ultimately mar gaye. So osimertinib, that is the third generation, that is mutant selective. And I told you which mutation, that is T790M mutation. Don't forget this EGFR. So guys, the drugs which are targeting this one, non-small cell lung cancer. If they ask about the VEGFR inhibitor, then don't forget Beva Ramu. So Ramu Beva hai. Then KRAS inhibitor, see the name Rasib. So KRAS is Rasib. EGFR, I already told you the important drug erlotinib, jaftinib, osimertinib, but I already told you about the dacometinib as well. Then I told you the ALK inhibitor. In ALK, the one important drug you need to know about ALK is crizotinib. So remember, ALK inhibitor is crizotinib and lorlatinib. Lorla is third, crizo is first. And ROS inhibitor again crizo and lorla. So that's why they are asking these two, because they are ALK as well as ROS1 inhibitors, crizo and lorla. I think every bacha knows, and obviously if you don't know, you should know about the BRAF. In BRAF you will get the RAF, dabrafenib. With dabrafenib we use the trametinib. So metinib and rafinib. So rafinib is BRAF and metinib is MEC. So we have dabra and trametinib, and we have the Encora and binimetinib. These combinations are used for these patients. So these two are very important combination, BRAF inhibitors. Then we have one important drug, that is MET inhibitor, and that is again you can see crizo. So you know crizo is having the multiple activity. Crizo and caboza, these are having the multiple activities. That's why they can be used. But don't forget the BRAF, very important. Don't forget the ALK, and don't forget the first VEGF. These are important. EGFR I already told you. Now comes to last one. These nowadays TRK, track. So remember the TRK, so tractinib. TRK is the tractinib. So these are the drugs. We have the drugs for these non-small cell lung cancer. These are immune checkpoint inhibitors. You should know the list of immune checkpoint inhibitors as well. In PD1, I told you in DVT as well, naye purane semi dost. In PDL1, we have the aate aave dur. Katla is pili or meli, pila mela hota hai, and leg pulling by the relatives. So nivo pembro semi dost, aate aave dur, pili meli or relately. So these are immune checkpoint inhibitors. So that is the answer. Okay, चलिए next question बच्चे. A patient receiving immune checkpoint inhibitor therapy nivolumab for melanoma develops severe colitis and pneumonitis, very dangerous complication. What is the mechanism behind these side effects? What is the mechanism? So a patient who is receiving the immune checkpoint inhibitors, you will find these pneumonitis, colitis, all these immune related problems will be there. So what is the basically mechanism behind this? So is this direct epithelial toxicity? No. Is this cytokine storm? No. Is this loss of self-tolerance due to PD-1? Yes. So it is the PD-1 inhibitor. The loss of self-tolerance leads to, because immune checkpoint inhibitor. If you inhibit these checkpoints, then what happens? Increase immunity, and that is going to cause the colitis, pneumonitis, etc. So if you see immune checkpoint inhibitors, these immune checkpoint inhibitors can cause side effects because they boost the immune system, leading to immune related adverse events. In this you will see the skin reactions like rash, itching. You can see the GIT like colitis, hepatitis. You can see the endocrine like thyroid disorders, diabetes. You can see the pulmonary like pneumonitis, and neurological like neuropathies. Even some myocarditis, some nephritis. You can see all these problems could be there, and these all are immune related reactions. These all are immune related reactions. So these are the immune checkpoint inhibitors main problem. So these are autoimmune problem. Okay, so this is the last question from my side. A patient with multiple myeloma, you know the drugs for multiple myeloma. In multiple myeloma, important drugs are there. It started on daratumumab, and later it develops repeated transfusion incompatibility. What is the most likely reason? Options are inhibition of hematopoietic stem cells, cross-reactivity with red cell antigens, CD38 binding interfere with compatibility testing, or complement mediated hemolysis. So guys, a patient with multiple myeloma started on daratumumab, and now after repeated transfusion, there will be repeated transfusion incompatibility. What is the most likely reason? So you know the daratumumab, important drug, that is targeting the CD38. CD38 binding, it is interfering with the compatibility testing, and that is going to cause this transfusion incompatibility. So guys, the common adverse effect due to daratumumab, is lymphopenia, neutropenia. This is due to bone marrow suppression, thrombocytopenia. And the second very common is infusion reactions. You can see infusion reactions are there. These are the common adverse effect. Then if you see why there is problem, so you can see the problem is due to, because daratumumab, it is going to bind with the CD38 on the RBCs, and that is going to have the pan agglutination, and indirectly the Coombs test will be positive. So it is the false positive. It is false positive result. Now how to avoid this false positivity? To avoid this false positivity, either you can use the DTT or enzymatic treatment of these cells. So you can remove or modify the CD38 from these cells, or you can do the phenotype matched or genotype matched blood products, or you can use, nowadays we have the actioned antigen typing as well, or the best thing, you can do pre-treatment of blood typing. Pre-treatment, you can block the antigens as well, or you can utilize the CD38 antibodies. So these are the strategies by which you can mitigate the interference. You should also know about the other drugs for multiple myeloma. In multiple myeloma, we have the drugs Zomib. You know the Zomibs, Bortezomib, Carfilzomib, these type of drugs are there. These are proteasomes inhibitor. We have the other immunomodulators like Thalidomide, lenalidomide like drugs are there. Thalidomide, lenalidomide like drugs are there. We can use the steroids like dexamethasone, prednisolone, and we have this, and one drug melphalan. So we are using the regimens, we are giving the combinations. One drug I already told you, daratumumab. So these are the drugs we are using for multiple myeloma. Don't forget the zomibs as well. So don't forget to revise the small molecule inhibitors. So this is from my side. I have done my best to revise some important topics. Now it's your turn to revise pharmacology if you don't want to do the MD in pharmacology, or you want to do the MD in your choice. So this is all from my side. Thank you. I wish you all good luck. Please revise the topics which I shared in first slide. These topics are very important, especially in INICET. You will find the questions from some new drug, from some anti-cancers, immunomodulators, some important questions from the antibiotics. You can follow my Instagram and I'm sharing some updates. You can follow this channel and you will find the updates about the new drugs as well. So that's all. Thank you guys. Wish you all good luck. Thank you. Bye bye. Take care. Namaskar.